Good afternoon, everyone, and welcome to today's Lunch and Learn webinar session titled Maximizing Knowledge and Performance of PrEP with Primary Care Providers, or MKaPP. I am Shannon Robertson, Director of Clinical Quality with Louisiana Primary Care Association. Our presenter for today is Dr. Byron Jasper. Dr. Jasper is board certified in family medicine with a master's degree in public health and currently practices HIV medicine and hepatitis C medicine at Open Health Care Clinic in Baton Rouge, Louisiana. He is a graduate of Tulane University School of Medicine and completed fellowship trainings at the Community Health Leadership Development Fellowship at Georgetown University School of Medicine and the HIV and HCV in Primary Care Fellowship at Providence Hospital in Washington, D.C. Additionally, Dr. Jasper serves as a community preceptor and guest lecturer with the Family Medicine Residency Program at Baton Rouge General Hospital. During this presentation, Dr. Jasper will provide an overall knowledge and awareness of pre-exposure prophylaxis, or PrEP guidelines, and help bridge the knowledge gap among medical residents and active medical practitioners in primary care fields through discussion around PrEP and discuss ways the MKaPP program supports these efforts. Just a housekeeping item. In order to stay within our time frame, we will hold questions until the end of the presentation. All participants will be in listen-only mode. Please type in your question throughout the broadcast in the question box located on the webinar screen. If we run out of time, you can email your question and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in this presentation. Dr. Jasper, you may begin.
All right. Good afternoon, everyone. Thanks for attending the lecture today. We'll definitely try to review as much information as possible within the presentation and also answer questions towards the end. The goal of the presentation is to, again, try to familiarize anyone who is in a primary care role with using the pre-exposure prophylaxis medication and also give providers a little bit more comfort with talking to patients about this subject matter. So we'll go ahead and get started. And if you are interested in doing the continuing medical education credit, there is a pre-test survey on the chooseprep.org website. It's a 10-question survey that we would like you to finish and do. And then after this presentation, we'd like you to also complete the post-test survey. And then from there, we'll definitely take your name and information to get you that CME credit. So to begin, the idea of what we're going to talk about today will be a little bit about the epidemiology of HIV and AIDS in the United States. We will also go over a few clinical trials, indications for PrEP therapy, and basically the steps you want to undertake when you're providing PrEP, things such as improving adherence from the patients, other information about financial assistance, and how to discontinue PrEP therapy as a whole. I'd like to quickly state that I do not have any conflicts of interest. And we'll also begin by going into HIV in the United States. So the first thing that we definitely want to talk about is the overall new infection rate in the United States of America. In 2014, the CDC focused and stated that the rate of new infections would be about 50,000 individuals in the United States. It's interesting to note that in 2015, this number actually went down to about 39,500. So it looks like some of these initiatives, such as PrEP therapy and other HIV prevention techniques, are starting to take some effect. To go a little bit further, the idea of who's most infected with HIV in the United States is pretty groundbreaking in the idea that men who have sex with men make up the overwhelming majority at 63%. This is followed by heterosexual women, also known as women who have sex with men, those that are injection drug users, and the men who have sex with men who also inject drugs round out this category. Specifically, going into disparities in the overall transmission of HIV, you can see that African American men and women are the group that is disproportionately affected among every other race and ethnicity. More specifically, men who have sex with men that are Black make up the overwhelming majority, And on top of the majority, they are followed by the white men who have sex with men category, and then the Hispanic and Latino men who have sex with men category. This has also brought up the idea that the black men who have sex with men category are the group that we should probably target the most with PrEP therapy, since they are often the ones that are most affected. We also see that black women who have sex with men are almost doubled, if not tripled, the amount of their counterparts in the white women who have sex with men and Hispanic and Latino women who have sex with men category. To take it one step further, African Americans, while only making up 12% of the United States population, in 2014 in the United States made up 50% of the new HIV diagnosis. Also, it's noted that the lifetime risk of HIV in men who have sex with men, broken down by race and ethnicity, you'll see that the African American male has the 1 in 2 chance of being diagnosed with HIV, compared to Hispanics being 1 in 4, and white men who have sex with men being 1 in 11. So all of that information is just a quick way to kind of show that HIV is very prevalent in the United States. It's prevalent in certain specific categories, and those are the categories that often, when you're thinking of who should get PrEP therapy, those are the ones you want to think about and target when you're sitting in your office and having a patient conversation and you notice those criteria are being met. We'll now go into some of the clinical trials that focus on PrEP therapy, and we'll start talking about why these trials are extremely important, and also highlight the landmark trials that help to kind of push this therapy a little bit further into the role that it is today. The first trial we'll highlight is the PrEP trial, and the PrEP trial took place in South America, the United States, Thailand, and South Africa. This trial was, the information from this trial was actually published in December of 2010 in the New England Journal of Medicine, and it basically stated that the group that took the PrEP therapy medication, which is tenofovir and emtricitabine, here it's broken down as TDF/FTC, the tenofovir emtricitabine group had a 44% risk reduction in the acquisition of HIV. Now, to make this a little more simple for anyone who's not a big statistics person, it means that when you had the group that took the medicine compared to the group that took a placebo, the group that took the medicine had a 44% chance, it was 44% better at reducing HIV acquisition in comparison to the placebo. So if they took the medicine, they were reducing their rate of infection by 44%. It goes one step further and shows that if they took the medicine consistently and they checked them and found that they had detectable drug levels in their system, it reduced it to 92%. Also, it was noted that the medicine was very well tolerated, and those people that were found to be infected after they enrolled into the treatment program, none of them had drug resistance, which is often an issue that a lot of providers worry about, thinking that if they give the medicine and the person becomes infected, will they develop resistance? And this trial actually showed that this was not a common finding. The next trial we'll talk about is the United States MSM safety trial. And in this trial that happened in 2013, the focus was to just determine if tenofovir was something that would be safe for people to take on a long-term basis for this specific cause. And it also highlighted that there were very minimal side effects, if anything at all. The most significant side effect in the trial was back pain, and we'll talk about side effects a little bit later in the presentation. It also demonstrated that it was an effective treatment for men who have sex with men, and it also showed that there was a very small decrease in bone mineral density, but the people who did have that decrease did not have any associated fractures. So the overall focus of the study was to show that the medicine was safe, and I think it demonstrated that very well. The next trial that we would go over is the Partners PrEP trial, and this one was another one of those landmark trials that actually was published in the New England Journal of Medicine in 2012. And in that publication, it studied the daily use of tenofovir emtricitabine or tenofovir by itself, and the idea was they took serodiscordant couples. So that means that one person in the couple was HIV positive and one person was HIV negative. In those couples, the person who is HIV negative would take the tenofovir emtricitabine or the tenofovir by itself and continue to basically do their normal daily routine, whether that's being sexually active or not. They would go about their normal routine while taking the medicine, and they would see who would acquire HIV. And those people who had a detectable drug level in their system at the end of the trial, the overall majority of those people had a 90% reduction in the risk of getting HIV compared to those who took a placebo. So this was another groundbreaking trial because the idea of it only being effective in men who have sex with men was the thought process for this medicine at the beginning, and this showed that it also worked in the serodiscordant couples. The very last trial we'll highlight is the Bangkok tenofovir study. And with the Bangkok study, they studied the population of intravenous drug users who were taking tenofovir with the idea of trying to get them to have a reduced risk of acquiring HIV. And those patients who again had detectable drug levels in their blood reduced their risk of acquiring HIV by 73.5%. And again, of the people who did become infected, who were infected at the end of the trial, they had no virus mutations, which also means there was no resistance to the medicine at the end of the trial if they became infected, even though they were only taking one of the medicines that would hopefully make up the full antiretroviral therapy regimen. There are many other trials that we could talk about, but the overall purpose of us highlighting a few of the trials is to show that daily oral PrEP therapy with the tenofovir emtricitabine medication is recommended as one HIV prevention option for the following groups: sexually active men who have sex with men who are at substantial risk of HIV, heterosexually active men and women who are at substantial risk of HIV, and the IV drug users who are at substantial risk of HIV. In those three categories, these are the people that if they're in your office and you're having an actual patient encounter and you notice some of these things are actually a part of that patient's history, is where you want to then broach that conversation about PrEP therapy in those specific groups. It's not meant for everyone who comes into the office. It's not like a medicine that you would give for someone who has a high blood pressure or diabetes. It's only for specific groups, and those groups are usually high-risk patients, and those high-risk patients are the ones that we usually target for this medicine. To take that one step further, we'll talk about the actual indications for PrEP within each of those categories. So before we go into actual category, each actual category, the overall thing we often try to emphasize to the people we present to is that you want to make sure you're always taking a brief sexual history with every encounter, not just for the high-risk patients, but everyone who walks into the door. I personally have patients come into my office, and all of the new patients, I ask the same type of questioning just to make sure that I'm not missing anything, and that always is something that's good practice to develop. That information is necessary to basically give every patient the best possible care and to make sure that people who are in the high-risk category aren't missed. And also be sure that you can reiterate confidentiality to every patient, because some patients may not feel like disclosing certain things because they often wonder if this information is going to be shared. So by reiterating that this is a confidential encounter and the things they share with you won't be disclosed to anyone else, will often have them at a little bit more of a easier state of mind. So for the men who have sex with men category, you often want to ask very simple, straightforward questions, and always asking them without the feeling that you're being judgmental, because patients can often pick up on that. So when I'm in the room with a patient, I specifically ask them, when you are sexually active, whenever you're sexually active, are your partners male only, female only, or both? And that is a simple way to get that question across without it seeming like you're asking something a little bit with a certain tone to it. And then from there, you can often ask how many. And if it's a person that you're having the conversation with and they disclose that they're sexually active with male partners only, and it is a male patient, you want to definitely ask, are they anal receptive or anal insertive? The idea of anal receptive or anal insertive sounds a little bit more technical than a lot of people are comfortable with, so the easier way to say it is, are you a top or a bottom? Bottom usually means anal receptive, a top usually means anal insertive, and sometimes the other part that we often forget is that sometimes they can be both. So we ask if they're a top, bottom, or both. And then you also want to ask them if they are knowingly engaging in sexual activity with anybody who's HIV positive. And if they are engaging in sex with someone who's HIV positive, you want to also ask them how many of those partners that they know of are positive, and if they are active, if they are actually on antiretroviral medication. Other things you can ask is, are they actually using any other substances while being sexually active? We'll go into the heterosexual men and women category, and again, the questions don't change much. It's just that you want to be a little more thorough in one area compared to another. So it's the same exact question. Are they sexually active with male partners, female partners, or both? How many partners have they had in recent months or recent weeks? How many times have they been in a sexual encounter that has been unprotected? And how many of those partners, again, are HIV positive? And with that, you can get a lot of information off those brief questions, and you can also determine if they are, for lack of a better term, high risk. If they are high risk, that will give you more reasoning to go further in your PrEP therapy encounter, or you can definitely say, well, this person is not high risk, and I feel like they don't need this medicine. The next category is injection drug users, and for the most part, we often think of them as being high risk just because they're injection drug users, but you have to consider that in certain areas, some injection drug users are a lot more sterile than others in the idea that they have needle exchange programs. So the first question is often asking, do they inject drugs, and when was their last use? And then you want to ask them, have they shared needles? Because if they are sharing needles, that's where your risk goes up. If they are sharing needles, you also want to tell them that they want to definitely try to look into needle exchange programs, because that's another prevention technique that we don't talk about too often. If there aren't any, then that's something different. But the other thought that we want to know is if they say they don't inject drugs and they are not sharing needles, you don't often assume that this person is potentially a former user. So you want to ask them, have they used previously? And if they did, when was the last time they used? And if they are enrolled in a program, that also potentially puts them at a higher risk. Last thing we'll talk about in terms of the screening portion of the presentation is basically knowing the overall HIV status of the patient's partners. Again, some patients will know this, especially if they are in a monogamous relationship. They often can tell you their partner is HIV positive or negative. They also should be able to give you an idea if they've had any sexually transmitted infections in the past 6 months. And you also want to ask them, are they using any illicit drugs, which could be IV drugs or intranasal drugs or inhaled drugs. If you also know the overall prevalence of HIV in the community that you're serving, that also is helpful, because that often usually gives people a little bit more of a higher risk than others if they're in a certain area that definitely has a high prevalence of HIV. So now we will talk about the indications for PrEP, which comes from the CDC recommendations from the 2014 CDC guidelines for PrEP therapy. So for the men who have sex with men category, if you have an adult male who is HIV negative and has had any male sex partners within the last 6 months, and they are not in a monogamous relationship with a recently tested HIV negative male, that automatically gives you criteria to think about PrEP. But you have to usually go one step further and say, well, not only are they in the first 4 categories, they also have anal sex without condoms. They've had sexually transmitted infections within the last 6 months, and they are also possibly in a monogamous relationship with an HIV positive male partner. So if you have one of the first criteria and you have one of the second criteria, usually that gives you more reason to say this person is definitively high risk and we need to give them this medicine, versus you're saying, well, I think they're high risk and I'm not 100% sure and I'm going to give them the medicine anyway. So again, if they're HIV positive male who has sex with male partners and they're not in a monogamous relationship with someone who's HIV negative and was recently tested, more than likely you're going to think of them as being in a high risk category. The next step of going into that information is heterosexual men and women. With the heterosexual men and women, it's very similar criteria. HIV negative man or woman who's sexually active and not in a monogamous relationship with an HIV negative partner that was recently tested, and they are having sex with both men and women. They are using condoms inconsistently, and their partner has an unknown HIV status, and they are also possibly in possibly in a sexual relationship with someone who's HIV positive. This would go into that serodiscordant couples category. So if those criteria are met, that patient should be in the high-risk category and is more than likely a good candidate for PrEP. The very last category will be the injection drug users category. And with that category, again, it's the exact same concept. The patient is HIV negative. They are injecting drugs within the last 6 months, and they are also sharing needles or other drug equipment. The idea of what other drug equipment would be, if a person is sharing straws when they're snorting anything, that is actually sharing of drug preparation equipment, and that can also promote HIV. It may not be as common as a needle, but it's actually still possible. Also, if they've been in a treatment program within the last 6 months, or if they're at high risk of getting it sexually. So if they fall into the other categories that we just talked about, and they're sharing some type of needle or injection or a nasal straw, then you'll say, well, this person is definitely high risk. So the bottom line of all of those things is when you have that category of high risk, whether it's a male who has sex with other men, a serodiscordant couple, heterosexual male that has many partners, a heterosexual female that doesn't use condoms all the time, they fall into high risk, and that means you then want to go a step further at figuring out, do they qualify for the medicine, and should they be placed on the medicine. With that being said, the one thing that we definitely want to spend a little bit of time on is making sure you understand that PrEP is not meant to replace condom use. I've had the question several times from several residents and medical students that if I have a patient who doesn't want to use condoms, should I give them PrEP therapy? And that question is very hard to answer because you are basically saying, well, am I going to promote them having sex without condoms? I think the question should be a little bit more into, are they going to be sexually active whether you give them the medicine or not? If they will, and you think they're at risk for HIV, giving the medicine is helping them to prevent HIV. It's helping them to prevent that infection and only that infection. And if you make it a point to tell them you should use condoms, I can't stop you from not, I can't stop you if you do or you don't, but I want you to know that this will not protect you from other things like gonorrhea, chlamydia, syphilis, and other sexually transmitted infections. So to answer the question, I usually tell residents or medical students, you want to tell them that you can take the medicine, but it only prevents HIV, and you want to make sure they know that it should be used in conjunction with condoms every single time, not most of the time, not some of the time, but every time. What they do after you educate them is on the patient, but as long as you do a fair amount of education, I think that you're doing what you're supposed to do. With that being said, the men who have sex with men and young adults are generally using condoms less frequently, so that's why you want to definitely make sure that if they are qualified to get this medicine, you want to do your due diligence to make sure they are able to get it by moving further in the encounter. And again, there are other methods to help prevent HIV. The biggest one that we often talk about is condom use, but again, abstinence is something that we often don't think about, and that's something we should also talk about if we have that in our mind that may be helpful for that patient. We'll now move on to the next part of the presentation, which is basically getting the patient onto the medicine. After you've determined their high risk and you know that this person is a patient who's interested, I think it's something that you want to know how to go about getting the patient on the medicine. So when you're starting the PrEP therapy medication, you want to do a few different things. You want to make sure that you test them, and when you test them, you're going to test them for HIV with one of two tests. A serum blood test where you're drawing blood from out of a vein, or you're doing a rapid finger stick. Those are the only two tests that you will do to determine if they're HIV negative. No oral swab should be used to determine if they're HIV negative. On top of that, you want to make sure that they are not having any acute HIV symptoms. The acute HIV symptoms are fatigue, malaise, fever, and rash. If they're having these and you haven't got a positive or negative test yet, you still want to just basically wait to give them this medicine. You also want to check their baseline renal function, and with the baseline renal function, you want to determine if they have a creatinine clearance above 60. If they do, then they're okay to take the medicine. If they don't, then that's something you do not want to give them. Specifically, if you have a patient who comes in and they're on dialysis, they are not indicated to get this medicine. The other thing you want to definitely determine is if they are hepatitis B positive or negative, and if they're positive, you want to keep them off the medicine. If they're negative, you want to try to talk about getting them vaccinated. The one thing that I've had a few residents ask me about is if they are not hepatitis C positive or negative, do you have to determine that in order to give them medicine? Right now, according to the CDC, you don't have to determine that, but we often recommend doing that test just to make sure you don't miss a patient who's Hep C positive. Now, once you've done all of those tests and the patient meets the criteria, you then usually are able to go ahead and give them the prescription to start the medicine. Now, once you give them the prescription to start the medicine, you want to make sure you tell them that this is something they have to take every single day. A question that often is asked by patients is, well, how long do I have to take it before I'm protected? And the very basic answer of that is not known. We don't know based on the studies that have been published. It's because different tissues have different levels on different days. So in the rectal tissue, in a patient who's a man who has sex with men, it seems to get to that area very quickly, being 7 days. But if you're a female and you're worried about it being in the vaginal tissue, it takes about a month to get there, being that it's about 20 days. So the idea of all of that is saying that since we don't know how long it would take you to be protected, we don't want to give you any chance of missing a medicine and not taking it consistently, and then you come back HIV positive. So we want to make sure you try to highlight to them that this is an everyday medicine. Now, as far as the medicines that are approved by the FDA currently for PrEP therapy, it's basically one medicine and one medicine alone in one category. In the first category, it is the tenofovir disoproxil fumarate, or TDF, and emtricitabine, which is FTC, and the trade name for that is Truvada. And that is, again, one pill once a day, every single day. There are alternative therapies that you can use, but it's only for specific categories, and that's injection drug users and the heterosexually active men and women. They can use tenofovir by itself, also known as Viriad, and that also is once a day. Again, Truvada Truvada is used with all categories, but the Viriad is only used with the injection drug users and men and women who are heterosexual. Men who have sex with men category cannot use Viriad by itself. Both medicines are in the pregnancy category B, which means it's safe to take if a person is pregnant. I often have patients come in to see me and they're pregnant, and they come in specifically for PrEP therapy because they have a male partner or a husband who's HIV positive and they want to have a baby. So we put them on PrEP therapy to help prevent the mother from getting it, and therefore we're helping to prevent the baby from getting it. So it is safe to take in pregnancy. And again, there are no alternative regimens that are currently FDA approved for men who have sex with men. There are newer medicines that have come out, but right now they are not FDA approved. We'll talk about adherence and monitoring. And with the adherence and monitoring, we've kind of already highlighted some of these parts. The thing that we often talk about at the very first visit, once we're given the medicine, is the side effects. A lot of times patients may not know of side effects, and if you don't educate them, they will stop the medicine pretty quickly, and that's kind of the opposite of, that is definitely the opposite of what you want to happen. So the side effects are usually very uncommon, and they usually go away pretty quickly. On the presentation, the longest that people will have them are usually a month, but most patients are about 4 or 5 days. The common side effects are usually things that are nausea, headache, gas, or skin rash, and then other things like diarrhea can also happen. The other things that you want to know when you're talking about adherence is how often the patients need to come in and do testing, and how often you should give them prescriptions. So the very basic thing you want to always remember is every 3 months, patients usually need to come into the office to be seen. And I usually tell the residents that I'm talking to and teaching that it has to be an inpatient visit. If it's not an inpatient visit, it usually is not something that you want to do. Excuse us 1 second. So usually with that, you want to make sure that they're coming in every 3 months. And when they come in every 3 months, you're telling them we're going to do blood testing and we're going to potentially do urine testing. If it's a heterosexual woman who is in the age range of possibly becoming pregnant, you want to definitely check a pregnancy test every time they come in. And you want to make sure that you give them only 90 days of medicine at a time. If you give them more than 90 days of medicine, some patients will not come back. If you give them 6 months of medicine, they will think that they're okay for 6 months and they will not show up. So it's only a prescription for 90 days, no more. If they don't show up for their appointment, they don't get a refill, because at that point, you don't know if they're HIV positive or negative, and them taking 1 medicine or 2 medicines and not a full regimen by being HIV positive could promote something called resistance. Of course, the other things you want to check often are their creatinine clearance to make sure their kidney function is still holding up against the medicine. You want to make sure that they are not having any other issues that could be screened for. And the thing that we specifically talk about is STI testing. The sexually transmitted infection testing is usually one of those things where I tell providers you want to do it based off of the patient. The guidelines may tell you do it every 3 months. The guidelines may tell you do it every 6 months, but the goal for me is often to make sure the patient is getting tested based off of their risk factors. So if you know it's a patient who's sexually active and they're not using condoms and they tell you they're not using it, you want to check in more often. Versus a patient who's in a monogamous relationship with an HIV positive partner and they are more than likely not going and doing anything else, you want to probably check it a little less. Again, there's no wrong answer to that, but the thought process is you want to check it as often as you need to. The very last thing that I often talk about is the bone mineral density question, which a lot of the people focus on the idea that tenofovir can cause damage to bones, and that is true. But the likelihood of it happening from taking the medicine is very, very low. It's known to happen in patients who've taken the medicine for longer than probably 5 or 10 years. So the idea of having the patient take it for a couple of months or a few years is usually not something that would happen. And even with that, the decrease in bone mineral density is very low still. So you can check a DEXA scan if you really feel you need to, but again, it's very rare and it's often not needed. The very last thing we've talked about previously is knowing again how often they need to take it. Right now, the recommendation by the CDC is every single day, 7 days a week. With 7-day-a-week dosing, the risk of them acquiring HIV is 1%, meaning their risk is reduced by 99% compared to them taking no medicine at all. Now, as you decrease the amount of pills you take in a week, you can see that the trend goes down about how much you're protected. So there are studies out right now where they're talking about if you take it several days a week or you take it as needed, and those studies are showing that there's still some risk. And then again, the bottom line is you want to make sure that patients don't get HIV, so we try to protect them as best as possible. So adherence is better with daily dosing, and the goal is to make sure they're always taking it every single day. Even if they wonder, can they take it only a few days, the recommendation to be in line with the CDC and the FDA is to take it every single day. And with that, it brings us to the question that we're often asked about getting the medicine covered. As I have told several providers, the medicine can be covered by a very high rate of insurance programs and also a high rate of patient assistance programs. You may have an insurance program that covers a part of the therapy, meaning it covers the medicine, but it doesn't cover the actual diagnosis. It doesn't cover the actual labs. It doesn't cover the doctor's visit. There's ways to get that figured out. So don't feel like patients who don't have insurance are often going to be without this medicine. The Truvada is made by a pharmaceutical company called Gilead, and Gilead has a good program that helps to cover the medicine and also helps with covering HIV testing. They also will help with co-pay assistance for the people who are coming in to get their visits. So the program is all-inclusive in a lot of ways, and then for some people where the insurance will cover the medical visit in the labs, that program may help to cover the medicine. So it's very easy to get the medicine. It may take some paperwork and registering for a program, but I think it's a lot better than the patient coming back with HIV and you having to do a lot more paperwork and other things at that point in time. When it comes to stopping PrEP, the idea is you want to make sure that the patient comes in and hopefully stops it with you and that patient having a conversation. You want to definitely document that patient's HIV status when they come off the medication, because you want to make sure that the person did not get infected while taking the medicine. And if the person ends up being HIV positive, you want to make sure that you document that did happen potentially while taking the medicine, and then you're going into a few more questions about how often were they taking it? Were they taking it every single day, or were they missing doses? After you also have the conversation about discontinuing it, you want to know exactly why. Is it because of side effects? Is it because of cost? Is it because of their status changing where they're no longer having multiple partners? Are they now in a monogamous relationship and they don't feel they need it? You want to document those things. You also want to make sure that if they're having the idea of going back on the medicine, you talk to them about when they want to go back and knowing that they're going to have to redo the medication workup again, where you're checking their labs and also checking their HIV status. And that brings us to the slide that is on the screen, and that is basically a quick cheat sheet on how you can figure out who needs PrEP and what you need to do to get them on the medication. It's broken down by categories of men who have sex with men, the heterosexual men and women, and the injection drug users. And it really is an easier way to kind of put it into perspective on who should get the medicine and what is needed in order to get them onto the medicine, what prescription you should give, and how often you should follow up, and the things you should do when you follow up. And that brings us to the final slide, which is the conclusion slide. And the overall thing that I want to make sure you walk away with from this presentation with is the idea that we know HIV is very prevalent in the United States, and it's posing a huge risk to a lot of people in America. The specific populations that it's posing the greatest risk to are the men who have sex with men population and, of course, minority populations. The idea of daily oral PrEP therapy is definitely effective at preventing HIV. It's safe for patients to take, and it's very simple in that they're only taking one pill, and the one pill is once a day. The financial assistance programs are definitely there to help patients with covering the cost of treatment or labs or diagnosis or actually having them cover the cost of medicine. And the overall thought process of taking the medicine should help to lower the risk of acquiring HIV by a very large number, as high as 90% or better if they're taking it every single day. And with that, this is our reference slide. And I thank you for tuning in. And again, I would like to highlight that if you are interested in getting the CME credit, you would go to the link on the bottom to the right of our website on chooseprep.org. You would complete the pre-test survey and the post-test survey in full. And once you do that, we'll be able to give you more information on how to get that CME credit. Thank you so much. And we'll now go into taking questions.
Thank you, Dr. Jasper. At this time, we will unmute the line for questions. As a reminder, you may also type your question in the question box located on the webinar screen. If you have a question, please feel free to ask at this time. Okay, it doesn't look like we have any questions. We'd like to take a moment to thank Dr. Jasper for conducting this presentation today. We will send out a copy of the slides to all attendees and post a recording to the LPCA website. As a reminder, please be sure to complete your surveys to receive the continuing education credit. This concludes our webinar presentation for today.
Hello?
Hello? Yes.
Hi, I'm sorry, I typed in the question. I guess it didn't get across. This is Dr. Antonio Finches. I did have a question. I missed the first part of the lecture, but has there been any known resistance created by lack of patients taking the medication every day or anything like that that Dr. Jasper is aware of?
Hey, Dr. Funches.
Hey.
Hey. So the studies that have been out have shown that if a patient is not adherent to the medicine, there's still a high possibility that resistance can happen, but that would basically get cut off if the patient is coming in every 3 months. So if you think about it at a very low scale of things, if you're taking the medicine and it's not a full regimen, but you're diagnosed pretty quickly, resistance takes a while to happen. Just like with antibiotics, if you're taking an antibiotic and you don't take it the right way, you won't develop resistance on the first week or the first time. So if you're not taking the medicine, if you're only taking the medicine a couple of months or a couple of weeks and you're diagnosed, the goal is to get them off of the half regimen or the partial regimen and put them on a full one. But if the person gets a prescription for a year, never comes and gets tested, gets diagnosed in February, and you don't realize they're HIV positive to December, then that's where your resistance may show up. So it's possible, but it's not a common thing. And all of the studies kind of showed that if a person's taking it every day, less likely. But also if a person is diagnosed and you diagnose them pretty quickly and they've only been on it for a short period of time, it's less likely the resistance will develop that quickly. Hence why they want you to come in every 3 months.
Okay, that makes total sense. The other question, when you're evaluating a patient that you're considering placing on PrEP, the testing that you do, does that account for, I know it's blood testing, does that account for the window period for like the acute HIV, say a patient isn't showing any signs of the malaise, fatigue, rash, and whatnot? Does that test still take into account of the window period? How effective are they at diagnosing like acute HIV?
Yes, sir. So the idea of testing is why we kind of talked about it being a serum test or a finger. The oral swab, you're looking at basically saliva, and in saliva, HIV takes a while to show up in your saliva. But in blood, that's the fastest you'll see. So that's why when you're doing those tests and you're ordering the specific test that you need, they're actually diagnosing HIV within a couple of days. So if you're contacting HIV Monday and you're doing blood testing on potentially a Wednesday or a Thursday, more than likely that test will pick it up, because the newer tests, specifically the 4th generation antigen antibody test, are the two tests, is the single test that you want because it's the best one right now. If you're still ordering the older test, 1st generation or 2nd generation, those are the ones where that window period is still possible, but a lot of the providers are moving away from those and now pretty much doing the 4th generation and nothing else. And again, the finger stick kind of does the exact same thing. That's a 4th generation test where you're taking blood and you're looking for the antigen and the antibody. And if you're getting either one of those, it's pretty quickly, it'll pick up the actual virus pretty quickly. So that's why you're doing those two tests, and it accounts for HIV really quickly compared to your oral swab.
Okay. Okay, that sounds good. And just personally, for you, how do you counsel your patients? Because one of the fears that I even talked with co-residents and whatnot is that, hey, you tell a patient that you can take this medication and help prevent HIV. How do you then counsel that patient to make sure that they're still practicing, safer sex or whatnot?
Yes, sir. I'm sorry, go ahead.
I said, so what is your personal technique if you have one?
So usually when I have patients that are coming in for PrEP therapy, every time I sit down with them, I always ask them, when was their last sexual encounter? Was it protected or unprotected? And then I ask them, how often are they using condoms to practice safe sex? The way I usually pose that question is, are you using condoms all the time, most of the time, some of the time, or never? And if they're actually answering those questions truthfully, you're basically giving them the idea that this is something we're going to talk about every single time. Are you sexually active? Are you using condoms? And then if you're using them, how often? That's usually the sexual side. Then I often still ask them, are you using drugs? If you are using drugs, what type of drugs? So the questions start to get repetitive, but the goal is once you start to build that rapport with the patient, you may, just like any other thing, know what questions you need to ask and what questions you don't. Specifically, if you have someone who's diabetic, you probably won't have to ask them about their dietary habits on every single visit because you'll know those things after you build that rapport. So with my PrEP patients, after so many visits, I know what questions to ask, and they usually are very honest and open with me because we've done it so many times that they feel comfortable telling me what they need to tell me. And I also ask those questions enough times where they feel like they know they're going to get them, so they want to definitely be truthful with me to help practice keeping the medicine and using it the way we're supposed to.
Okay, perfect. That's all from me.
Thank you.
Okay. All right, good advice. So we do have one more question. Once we take the initial history and physical and lab work, should we refer our patients to specialists to manage the PrEP therapy?
So I often will tell primary care providers that you do not have to refer people to specialists unless you don't feel comfortable. If you feel like you're doing testing and you're out of your scope, then you definitely want to refer them. It's just like I tell a lot of the patients I deal with, it's equivalent to me trying to do sutures that I don't feel comfortable doing. I don't say, well, look, I think I can do sutures, so let me go ahead and take a crack at it. I tell them, look, this is my comfort. I'm comfortable at this level, and at that time, this is what I feel like I can do. So when it comes to PrEP, it's like anything else. If you're practicing this and you're getting more patients, you're going to feel more comfortable. So the goal would be to do a little bit and get more comfortable, and then do that. Like you can do that, then definitely you can refer them to someone who does PrEP therapy. A lot of people, but primary care providers are very well equipped to do this because it's like anything else. The more you do it, the better you're going to get at it. And all it is basically doing labs and asking questions, which we do every single day.
Okay, and we do have a few more moments to take another question if we have one. In the meantime, we want to thank Dr. Jasper for conducting this presentation. And again, we will send out a copy of the slides to all attendees and post a recording to the OPCA website.
All right, thank you.
Okay, this looks like all of the questions for today. This concludes our presentation. Thank you for participating. Everyone have a great day.
You too.